welcome to this episode, where we're diving deep into congenital musculoskeletal conditions. These are complex disorders that can be apparent right at birth or sometimes reveal themselves subtly over weeks or even months. Today, we're unpacking a range of these conditions, from arthrogryposis and achondroplasia to developmental dysplasia of the hip, clubfoot, metatarsus adductus, congenital limb deficiencies, and osteogenesis imperfecta. We'll explore their pathophysiology, clinical features, diagnostic challenges, treatment strategies, and the critical role nursing plays in managing these kids.
Yeah, it's a broad spectrum, and what strikes me is how early recognition and intervention can really shape outcomes. These conditions often require a multidisciplinary approach. Nurses, orthopedists, rehab specialists, genetic counselors, all working together. So Leah, maybe we can start with arthrogryposis multiplex congenita, or amyoplasia. It's rare, but quite distinctive.
Absolutely. Arthrogryposis is fascinating because it's a non-progressive congenital condition characterized by multiple joint contractures and muscle hypoplasia or fibrosis. The incidence is roughly 1 in every 5 to 10,000 live births. What's interesting is that the exact cause remains unclear, but theories include restricted fetal movement due to uterine constraints, early viral infections during fetal development, or abnormalities in the central nervous or muscular systems.
Right, and importantly, it's not inherited, which is a key point for genetic counseling. The classic presentation, amyoplasia, is symmetrical and includes internally rotated and adducted shoulders, extended elbows, pronated forearms, flexed wrists and fingers, dislocated hips, severe equinovarus contractures of the feet, extended knees, and hypoplastic fibrotic muscles. But despite all these physical challenges, intelligence is typically normal, which is reassuring for families.
That's a critical point. Diagnosis relies on a thorough history and physical exam, but adjuncts like radiography, muscle biopsy, and blood work can help. Treatment is multidisciplinary. Intensive physiotherapy and occupational therapy to improve joint mobility and muscle strength, and sometimes orthopedic surgery to enhance joint function. The condition is stable, not progressive, but residual limitations often persist.
From a nursing perspective, education is vital, helping families understand the importance of therapy and supporting adaptation to functional limitations. Plus, monitoring skin integrity is crucial, because contractures and immobility can predispose to breakdown. It's a delicate balance between encouraging activity and protecting vulnerable skin.
Exactly. Moving on, achondroplasia is probably the most common genetic dwarfism. It's caused by a mutation affecting cartilage formation, leading to disproportionate short stature. The incidence is about 1 in 20,000 live births. Most cases arise from new mutations, but if a parent is affected, there's a 50% chance of transmission.
The clinical features are quite distinctive. Shortened limbs, especially the proximal segments, which we call rhizomelia, a large head with a prominent forehead and flattened nasal bridge, lumbar lordosis, and sometimes a kyphosis near the shoulders that often resolves after walking begins. One of the more concerning features is the small vertebral canals, which can risk spinal cord compression. This can unfortunately lead to sudden infant death due to respiratory compromise.
That's a sobering aspect. Other features include bowed legs, flat, broad feet, the so-called trident hand with extra space between the middle and ring fingers, hypotonia, joint laxity, and frequent middle ear infections that can cause hearing loss. Intelligence remains normal, but developmental milestones like walking may be delayed, often occurring between 18 and 24 months instead of around 1 year.
Diagnosis can be prenatal via ultrasound, which can detect characteristic features, or postnatally through clinical exam and DNA testing. Treatment options are limited. Growth hormone therapy has minimal effect on height, and surgical interventions may be necessary to address kyphosis or leg bowing. Vigilant monitoring for signs of spinal cord compression is essential.
Nursing care here involves educating families about neurological signs to watch for, supporting developmental milestones, and coordinating multidisciplinary care, including ENT for recurrent ear infections. It's a complex picture that requires ongoing vigilance.
Definitely. Now, developmental dysplasia of the hip, or DDH, is another critical condition. It's a spectrum ranging from mild acetabular dysplasia to frank dislocation. The incidence of hip instability is about 10 per thousand live births, with dislocation occurring in roughly 1 to 1.5 per thousand. There's a strong female predominance, about 80%, and a familial predisposition in up to a third of cases.
The etiology is multifactorial. Physiological factors like maternal hormones and intrauterine positioning, mechanical factors such as breech presentation, oligohydramnios, multiple fetuses, and genetic factors, including higher incidence in siblings and girls. DDH is categorized as idiopathic, where the infant is neurologically intact or teratological, associated with neuromuscular disorders like arthrogryposis.
Pathophysiologically, we see acetabular dysplasia, which is the mildest form with a shallow oblique acetabulum but no dislocation. Subluxation, where the femoral head is partially displaced but still in contact with the acetabulum. And dislocation, where the femoral head loses contact entirely and is displaced posteriorly and superiorly.
Diagnostically, the Barlow and Ortolani maneuvers are key in newborns up to 4 weeks old. The Barlow test identifies a hip that can be passively displaced, while the Ortolani test detects a dislocated hip that can be reduced. But these tests must be performed gently by experienced clinicians to avoid causing injury. Ultrasound is preferred for early imaging since the femoral head is cartilaginous, with radiographs becoming useful after 4 to 6 months. MRI is often used post-reduction to assess femoral head position.
Clinically, infants may show leg shortening on the affected side, asymmetrical gluteal folds, restricted abduction, and positive Barlow or Ortolani tests. Older children may present with limb length discrepancy, Trendelenburg gait, a prominent greater trochanter, and in bilateral cases, a waddling gait.
Treatment depends on age and severity. For newborns to 6 months, the Pavlik harness is the mainstay, maintaining the hip inflection and abduction worn continuously for 6 to 12 weeks. If the harness fails, closed reduction and spica casting are options. Between 6 and 24 months, hip abduction orthoses, traction for contractures, and surgical reductions may be necessary. In older children, surgical interventions like pelvic and femoral osteotomies are often required, but outcomes worsen with age due to adaptive changes.
Nursing care is pivotal. Early detection through vigilant hip exams during routine infant assessments, educating parents on harness use and skin care, and adapting nurturing activities to accommodate devices. Also, it's important to avoid forced hip extension in infants to prevent DDH. And a couple of safety alerts. Vigorous Barlow or Ortolani testing in the first 2 days of life can cause harm, and double or triple diapering is contraindicated as it promotes hip extension.
Those are crucial points. Moving on to clubfoot or congenital talipes equinovarus, it's a complex deformity involving forefoot adduction, midfoot supination, hindfoot varus, and ankle equinus. The foot is pointed downward and inward. Incidence is about 1 in 1,000 births, with boys affected twice as often as girls, and half of cases are bilateral.
The etiology is unclear, but has a strong familial tendency. Intrauterine positioning and restricted movement are implicated. Clubfoot is classified as positional, syndromic or teratological, and congenital idiopathic. Positional is mild and often corrects spontaneously or with passive stretching. Syndromic is associated with other anomalies like myelomeningocele and is resistant to treatment. Congenital idiopathic or true clubfoot involves bony abnormalities and usually requires surgery.
Diagnosis is usually at birth or prenatally via ultrasound. It's important to differentiate from positional deformities by assessing rigidity and response to manipulation. A thorough hip exam is essential due to the association with DDH.
Treatment centers on the Ponseti method. Weekly gentle manipulation and serial long leg casting starting shortly after birth, typically over 6 to 10 weeks. A percutaneous Achilles tenotomy is often performed to correct equinus, followed by casting for 3 weeks. After casting, abduction braces with a bar maintain correction and prevent recurrence. Surgery is reserved for refractory cases.
Nursing care involves skin and circulation monitoring during casting, parent education on treatment phases and adherence, and supporting normal development within therapy constraints. Recurrence can happen, especially at 2 to 3 years or during adolescent growth spurts, and orthotics may be needed for residual symptoms.
Then there's metatarsus adductus, probably the most common congenital foot deformity. It's often due to intrauterine positioning, especially in firstborns. It's characterized by medial adduction of the forefoot with normal heel and ankle alignment.
It's classified by flexibility. Type 1 is flexible and corrects easily. Type 2 is partially flexible, and Type 3 is rigid and usually requires casting. Clinically, it causes a pigeon-toed gait. Again, a hip exam is necessary due to increased DDH risk.
Treatment for types 1 and 2 involves gentle stretching exercises taught to parents. Type 3 requires serial casting followed by corrective orthoses. Surgery is rare, reserved for persistent deformity causing pain or shoe-fitting issues. Nursing roles include early identification, parent instruction on stretching, and cast care if applied.
Congenital limb deficiencies cover a range from minor digit defects to complete absence of limbs, like amelia, or partial absence, like meramelia. Etiology includes genetic factors and environmental insults, such as the thalidomide tragedy. Associated anomalies are common: cardiovascular, CNS, renal, digestive.
Management involves early prosthetic fitting aligned with motor development milestones. Surgical modification may be necessary to optimize prosthetic use. Prostheses evolve with the child's growth and capabilities. The interprofessional team includes prosthetists, physiotherapists, and occupational therapists.
Nursing care focuses on supporting family adaptation, encouraging age-appropriate independence, and avoiding overprotection to prevent maladjustment. It's a delicate balance between assistance and fostering autonomy.
Finally, osteogenesis imperfecta, or OI, is a genetic disorder of defective type 1 collagen synthesis causing bone fragility. Most cases are autosomal dominant, with some recessive forms. There are at least 8 types with variable severity.
Type 1 is mild with blue sclerae and hearing loss in adulthood. Type 2 is lethal in infancy. Type 3 is severe with multiple fractures at birth. Types 4 to 6 have moderate severity with unique bone features, and types 7 to 12 are rare recessive forms.
Clinical features include frequent fractures, bone deformities, blue sclerae, dentinogenesis imperfecta, and hearing impairment. Cardiac involvement is possible. Diagnosis requires differentiation from non-accidental injury, using genetic testing and clinical history.
Treatment is primarily supportive. Bisphosphonates like pamidronate or zolendronate increase bone density by inhibiting osteoclasts and stimulating osteoblasts. Vitamin D and calcium supplementation are adjuncts. Physiotherapy prevents disused osteoporosis and strengthens muscles. Surgery, such as intramedullary rods, corrects deformities and stabilizes bones.
Nursing care requires gentle handling to prevent fractures, educating families on safe positioning and care, and providing psychological support. Genetic counseling is important due to the 50% transmission risk. And a key safety alert: children with multiple fractures should be screened for OI before assuming abuse.
That's a critical point. So to wrap up, early detection and multidisciplinary management are essential across all these conditions to optimize outcomes. Nursing plays a pivotal role in education, device management, skin care, and psychosocial support.
And balancing protection with promoting normal development and independence is a recurring theme. Advances in genetics and imaging have really improved diagnosis and personalized care, but the complexity and nuance in managing these congenital musculoskeletal conditions remains significant.
Absolutely. Thanks for exploring this with me today.
Thank you. It's been a thorough and insightful discussion.